Uh, I am Dr. Subhasis Mahanti, Joint Director Health Services, Vector 1 Disease, Odisha State. And I'm here in this post since 3 years. And today I will be presenting on lymphatic filariasis change in perspective, Odisha context. And as we all know, to start with the background, as we all know, lymphatic filariasis is a neglected tropical disease that is transmitted by mosquitoes, maybe culicin, Mansonoid, and Anopheles, and caused by Brugia malai and Ukiria bancrofti, also by Brugia timori nematode. And a single dose of MDA or mass drug administration with DEC and albendazole to the population under risk and providing morbidity management support to the affected are the two twin pillar strategy that has been adopted under ELF program. And if I will discuss about Odisha, then in the entire country, MDA was commenced from 2004, and initially in 2004, 20 districts were taken in the state of Odisha where DC was started, and after 2007-8, albendazole were added to it, and out of 30 districts, we do have 30 districts, and out of that, 20 districts were taken during that period, and rest 10 districts were not part of MDA program. So a hidden risk of LF infection in the community was there, and it was left unmonitored. And if we could have done the exercise earlier, the actual disease scenario might have been different, and over the years, and the population of the district, those who are living under the risk of contracting disease, could have been addressed. And objective of this presentation was to understand the actual disease burden of lymphatic filariasis in the non-MDA or endemic districts, non-endemic district, to understand preventive measures based on the disease burden, and to provide morbidity management and disability prevention services to the affected. So here we can say that in the state of Odisha has become the first state to have integration of both DPMR and MMDP services that has been approved by Government of Odisha, and at the facility level we are integrating the services of DPMR clinic and MMDP services now. And if you go to methodology in the year 2018-19, morbidity mapping of Rayagada, all those 10 districts were done, and based on the caseload, sentinel sites were selected. And from each district, 4 sentinel and 4 random sites were selected. A total of 8 sites were taken for the NBS activity, that is a night blood survey activity. From each site, 500 blood smears were collected from the community, except for children less than 2 years of age, between 8:30 to PM to 12 midnight. These slides are further dehemoglobinized, fixed, stained, and screened by competent LT, those who are trained. And per district, around 4,000 slides were collected and screened for all 10 districts. So some glimpses I have given in the picture also. Next. And result what we got is based on that NBS assessment. 7 districts, that is Kanmal, Sonpur, Sambalpur, Sundargarh, Keonjhar, Mayurbhanj, and Bargarh, were having at least one site MF rate of more than 1%. And this was the contradiction to, or it is different from the previous observed status of non-endemic LF status. And this observation shows the need for the implementation of mass drug administration program in these 7 districts to break the chain of transmission. So if I will go to uniqueness of this concept, that this was the first ever venture done in ELF program, that is elimination of lymphatic filariasis program, to address hidden morbidity burden in those non-endemic districts. And in view of elimination drive to estimate the actual disease burden and linking them to MMDP services and breaking the hidden transmission chain and creating awareness among people regarding LF and availability of MMDP services utilizing this platform. And all the activities were carried out through effective intersectoral coordination through involvement of WHO, ROFW, PCI, PRA members, Gaon Kalyan Samiti members, ASA, school and mass education department, all departments were involved in this procedure. And challenges that we faced during this exercise is that, please, next slide, please. That because these are the non-endemic district, administrative approval from higher level was not there to conduct full-fledged MDA activity. And the state could advocate with NCVBDC Delhi, Government of India, with the evidence-based finding and get the approval for the incorporation of these districts under MDA. And as there was no approval, no fund provision was there, and drugs for MDA and other logistic support for as a contingency also not there. And evidence-based proposal was prepared with the importance of how we resolved that. An evidence-based proposal was prepared with the importance of urgent addressing the scenario and submitted through proper channel to Government of India, and we managed to get the approval. And third challenge was non-availability of adequately trained manpower and sticking to time frame, because but due to less resources, less trained faculty for training, only ROFW was there to train for filaria microscopy. So immediately at the field level to get trained LT to do NBS was difficult, but with the help of ROFW, we could able to conduct. And in a larger scale, initially we trained 60 LTs and then gradually upscaled. And community reception regarding this was because we are conducting this activity for the first time. We conducted intensive ICBCC activity with the with the involvement of Center of Excellence, that is Director SIW, and the PCI organization was also there for social mobilization activity. And we could ask NHM for special innovation fund under ICBCC, so that MDA corners were placed in different facility level, and finger marking was sample based. It was conducted in few places. And implementation of ELF activity in a district with no history of ELF program, that was a challenge. So we started with state level sensitization, and then at district level we conducted state level intersectoral coordination meeting, that is state task force meeting. At district level, district intersectoral coordination meeting or district task force meeting, block task force meeting. At block level it was conducted, and we try to take it up to village level through Gaon Kalyan Samiti, and their PRI members and Anganwadi workers and all ASAs, teachers, all were there. Through them also we try to motivate people and create awareness. And regarding scalability and replicability, next, the initiative has every potential to be scalable and replicable, because it was after 15 years of starting the program in the state, that is 2014 to 2018-19. So we could able to show a path to the entire country that it can be measured, and it can be replicable, because next three districts, Balangir, Raigada and Kalahandi was there. That was not those among, out of those 10 districts, 7 were in 1819. They have got MF rate of more than 1, but still 3 districts were there that needed remapping, because at that point of time it showed less than MF 1%. So it was scaled up again. Remapping was done in those 3 districts. Again, we found MF rate of more than 1% in one of the sites. So scaling up has already been done, and it can be replicable in other states, because mapping the disease burden in non-endemic area is highly important in the context of filaria elimination, but because national goal is for elimination by 2030. So, and regarding excellence, I can say that as of the year 2022, 2 effective round. Next slide, please. Next slide. As of the year 2022, 2 effective rounds of MDA have been completed in these districts with MMDP kit provision to all the line listed lymphedema cases. And Odisha was the first state in the country to map the disease burden and implement MDA in non-endemic districts. And in terms of public health interest, this was a tremendous and game changer step for Odisha and also for the LA program in the country. And our future roadmap is that providing 100% MMDP services, that is morbidity management and disability prevention services, to all beneficiaries. That is for lymphedema cases, provision of MMDP kits, and if acute attack occurs, facility-based survey, facility-based treatment, and in case of hydrocele cases, hydrocelectomy at facility level where good quality trained manpower is there and good quality OT facility is there. And intensive integrated vector management activity, we do have entomological structure in our state. 2 zonal entomological unit is also there, and 1 state entomology unit is also there. And vector control measures are being taken, or LLN distribution has been done, covering a population of 2.8 crore population. What is most important is that due to this effort, due to this exercise, 1.13 crore population got the benefit of this decreasing the burden of this disease. And all the MMDP services for hydrocelectomy, we have assessed that around 16,000 hydrocele cases were there. They are put on track for hydrocelectomy, and we are in the process of covering all the hydrocele cases, and MMDP services has been provided to more than 20,000 people living in that high burden areas. And introduction of now Government of India and Government of Odisha is in the process of introducing IDA, so that elimination will be process will be hastened in this district with 2 to maximum 3 rounds of effective IDA. Because in under DF MDA, when 2 drugs are used, it takes at least 65%, more than 65% coverage with 5 good rounds. So, but with IDA, 2 rounds with more than 85% coverage will be good enough, because we know that with the introduction of addition of ivermectin, maximum microfilaria, more than 90% microfilaria were killed by ivermectin. So this is my presentation. Thank you all.
That's a very good presentation. Can this disease not be treated by any vaccine?
No, sir. There is no vaccine for lymphatic filariasis yet developed.
Okay,
because this is a neglected tropical disease, and it is a chronic disease, so no vaccine is available for treatment of.
And how much is the treatment time generally?
Sir, it is a mass drug administration. Annually, it is done. If 2 drugs are used, DEC and albendazole, as per age category, then a single dose is sufficient annually for 5 good effective rounds.
Okay.
So
okay. Thank you, Doctor. Thank you,
Yes.
Dr. Thank you, please.
Thank you, sir.
Good presentation and good work, sir. No specific question to ask. Thank you.
Thank you, sir.
Long-lasting insecticidal led distribution in the state of Odisha. A little bit of let me start with a little bit of introduction that Odisha was contributing around 40% of the national malaria load in around 2012, and almost in 2016 we had a case load of around 4.44 lakh cases of malaria in 2016. In 2017 we have distributed these long-lasting insecticidal nets that are mosquito nets impregnated with synthetic pyre thread. We have we received it from government as a kind grant, and we have distributed this to the whole the high burden areas in the state in 17. That resulted, along with other measures, a drastic reduction of number of malaria cases in the state. It come down almost drastically from 4.4 lakh cases to 45,000 cases during 2020, and last year in 2021, the total case are come down to around 25,000 cases. That means almost more than 90% reduction in total case load. So these nets have a lifespan of 3 years. The insecticide property lasts for 3 years. So we are due to distribute another lot. We did distribute another lot during the year 2020-21 because the first lot was distributed in 2017, and after 3 years of its insecticidal lifespan, we distributed around 1.656 crores of these LLIN in the state of Odisha. Again, one more thing to say that with the high burden districts, out of the total malaria burden, we get nearly 80% of the cases from 7 southern districts, which are hilly districts dominated mostly by the tribal population. The challenges are they are tribal people, low literacy, low health seeking behavior, low there some socio-economic scenario is very, very challenging for use of insecticidal nets and also distribution of these nets. Then we have one more challenge was this was again during the period of COVID pandemic. So taking all these into consideration for the protection of these tribal population in the identified high burden areas in the priority basis to reduce the malaria case load, we had undertaken the activity in 2020-21. The critical interventions, there are a lot of preparation before going to the distribution. A state-specific guideline was developed. We have decided because every village has a Gaon Kalyan Samiti. This takes care of the health need of the village. Now these Gaon Kalyan Samitis are roped in. Wide dissemination of LLIN messages were given in advance so that they are aware of the fact that a new lot is going to reach there and how to be distributed. Then keeping the record for full transparency, how much is being taken to what subdivision, what block, and how much to be given in that particular village or panchayat, taking into consideration the policy we have decided depending on the number of household members, how many nets are to be given. It was pre-planned earlier on head count and has been done by our health field staff. Again, there are involvement of all other sectors, government sector like forest department, like child and women development department, the school and mass education department, the teachers, the local PRI representatives, and again the district administration as a whole for this distribution activity. Now there is a innovative social mobilization campaign. We call it in our local language a mascot called Nidhi Mausa that has been used to popularize the use of LLIN and efficient distribution. Then adopting a complete saturation of one district. We have decided that one district or a high burden area to be fully saturated. Then emphasizing on a meticulous LLIN distribution plan that have been done in advance and disseminated among people and among the planners at the district level. Then for that, a state level committee again did the planning for involving all the collectors at the district level. Then series of consultation at the district, at the state level, district level, block level, village level, everywhere there is planning for making the head count, for making the plan ready in what area to be distributed in what day. Then and the way of the logistic supply chain management, how it to be received. Sorry, it is, I think it has gone off the screen.
Yes, sir, your screen got disconnected. Could you just reshare?
Okay. active involvement, support of other line departments and other officials and the Panchayat Raj institution and elected representatives. Then excuse me, there are some issues with the PPT again. Yes. Is it changing now?
Yes, sir. It's changing, sir.
Yes, sir. So these are the steps we have taken. We have estimated the risk population, then calculate the requirement of LLN, then prioritize distribution to a mass supply, then planning at the state level, where from we will receive it from the consignment that we received that is coming from the train, then taken to the state warehouse. We have again regional warehouses, and there are 4 regional warehouses. Then therefrom, we have to plan a transporter who will carry them from the regional warehouse to the district and sub-district level. And there is also the launching of IEC and BCC campaign before distribution, so that the people are quite aware and sensitive regarding use of the new LLIN. And we have to again plan this very, very meticulously so that it reaches every area in the scheduled date and time as per the required number. Then like pulse polio, the LLIN could be distributed a single day in a particular geographic area. It was planned that it will be given in one day. Suppose it in a block, it will be saturated in one day, so that there is no spillage, there is no complication, there is no people will not think that we are not getting it, there is no complaints. So we have taken it into account. We have saturated in a particular geographic area in one day. Then if suppose there is leftover, then it is followed up with a mop-up round. So it was effectively done. One of the districts that is called Keunjhar could distribute around 10 lakh LLIN in a span of 2 days only. The entire district administration was involved, as I told, from the level of collectors down below to the Gram Rakhis, the SSG members, the PRI members, and all the home guards, the Panchayat, the forest guards, etc. So these are the 3-tier distribution plan. There is pre-distribution activity for sensitizing people to make them aware that this household is getting 2 or 3 mosquito nets, on what day it will be distributed, and how to use this. Then during distribution, again, we have to ensure that the COVID appropriate behavior was ensured. That again, suspected people then coming there are provided with the testing. Suppose somebody is symptomatic, he is isolated, given testing, and it seen that the consignment reaches his home. And then post distribution, again, we have to make people aware that they have to use the new LLIN, because the old LLIN, the insect settled property, has reduced. This is a challenge because people have the habit of using the older one and storing this. If you store this again within the next 3 years, it will lose its property. So the challenge is to sensitize these people, particularly these people, those who are tribals, lowly literate, with low level of sensitivity to these issues. So these activities was planned very, very meticulously. Engaging GKs at the village level was a big advantage. The people got involved there, the local leader, the peer leaders, and elected representatives got involved there. Then we have conducted street theaters. Then messages were given, posters were put on. School children are sensitized. Then before that, for sensitizing people after the distribution, now people are sensitized to use this by different innovative methods, like ringing the bells, creating a whistling in the area to remind that this has to be utilized. Even going house to house to demonstrate how to fix up it in the wall and how to use this, because they are very, very tribal and low literate people. These activities continued. The post-distribution activity was almost carried out by our ASAs and Anganwadi workers and health workers to sensitize people that they have to abandon the older.
Sir, sorry to interrupt you. You have got another 2 minutes.
Okay. So these are this is the distribution plan. That is how we went ahead. Then the whole thing again resulted is in 2021. We have now it is resulted in further reduction of around 25% case load last year, from 45,000 to coming down to 25,000. This year also till date we have another 15% reduction. So this is a very good intervention, and the whole purpose was to sensitize these 7-8 districts. These are high burden districts, contributing about 80% of caseload in the state, and mostly these are tribal and hilly terrain and tribal people. So the administrative machinery, gearing up, doing a pre-planning well, and distributing this was a challenge. This model has the scalability and replicability. It can be upscaled in larger states, can be replicated in other states too. We have a hassle-free distribution without any complaint, without any spill forage, without almost any damage. The future roadmap we can, because this can be go on. This activity can be repeated every 3 years. We have to repeat it. We have to again new strategy intervention like active involvement of SSGs and further intervention regarding LLL maintenance in prolonged insecticidal efficacy. So this is our experience in the state of Odisha that has resulted in a drastic rise of the fall of around 90% malaria case load and a substantial reduction in the malarial death. Almost last year, the malarial death load came down to single digits, and this year, till date, we do not have a single death, and particularly in these high burden districts, there is again reported fall of the annual parasite index and the number of cases in these particular districts that I can name them, like Malkangiri, like Koraput, like Rayagada, like Kanmal, then the Kalahandi and Baud. These are our high focus areas, mostly dominated by the tribals. And what is the assessment now? The post LLI and distribution assessment says there is almost about more than 80% usage of the newer LLIN. That I believe is a very, very good intervention as far as saving the life and sensitizing people in using this barrier method of controlling the vector, that is the mosquito, in transmitting the malaria parasite. Thank you very much for the patient listening.
Thank you, Dr. Mishra. I think this is a very good initiative to serve the tribal people, the grassroots people. In fact, you have done excellent work. But besides this, what other interventions are there? The malaria.
Yes, sir. This is not a alone one. This is not one. There are 4-pronged strategy we have adopted. One is there is what you call integrated vector control. This is one aspect of vector control. Other aspects are reducing breeding sites, taking care of the sanitation, stagnation of water. These are one aspect. Sensitizing people to clothe themselves, covering themselves, and reporting very, very early in fever cases so that they are tested early. All positive cases are tracked till the end of their treatment so that there is no death. So early diagnosis and a complete treatment for 14 days. This is what is called EDCT, early diagnosis and complete treatment. And in addition to this, we have a state-specific program called Daman. This is called, in this program, a large number of inaccessible villages are targeted, where regular surveillance is a problem. We have conducted twice a year surveillance of all people in these hilly areas, which we cannot access every now and then. So that every 6 months we conduct a camp there, do testing of all the population, whatever are positive, given treatment, so that the parasite load in that community comes down to break the transmission. This is effectively a very, very Odisha state specific activity. We have done it marvelously well to reduce the caseload, as I have told you the data, and it has worked very, very well. We are still continuing with that. So accessing these villages, those where there is an issue of traveling, not only malaria surveillance, we have integrated other health activities like immunization, like pregnancy checkups, like anemia checkups, like nutritional counseling. So we all integrate in this Daman camp. We call this a Daman camp. We conduct twice in a year. So all activities, health-related activities through this Daman camp delivered in these tribal inaccessible areas, so that has resulted in quite good number of reduction in malaria. Almost it has nil this year.
Thank you, Dr. Saab.
Good work, sir. Thank you. I don't have any specific question to ask. All the best to you.
Thank you, sir. Thank you very much.
Ashwasa Nidhi by the state government of Kerala. that has been implemented by the Women and Child Development Department, Kerala. It's a scheme for the victim. It's a kind of victim compensation scheme. Other than the victim compensation scheme given by the government for the after the trial or before the pre-trial. This is given as soon as a child or a woman is has undergone gender-biased violence. So it's the first slide is about the project. That is, we would like to identify the survivors first, and we would categorize them. And according to their needs, the financial aid is given to them. We know that a financial aid cannot take back their trauma or cannot minimize the trauma, but just to give them some sort of financial aid for their medical facilities, as well as for the domestic violence survivors, to start up a small unit to find out a livelihood. For burn injury, for acid attack survivors, we are giving this Ashwasa Nidhi. This is called Ashwasa Nidhi, which means Ashwasa means it is a kind of relief. The Malayalam word Ashwas means it's a relief for which is given financially, aided by the government. For that, in the state government, in the planned fund, we are allocating around 2 crores of rupees now. The last year we had met it around 3.5 crore rupees. It was implemented in the year 2018. And from then on, before that, we had a small scheme for the domestic violence survivors, only for the domestic violence survivors. But from 2018 onwards, we are addressing all the gender-biased violence. And for them, we are giving a small financial aid. As soon as the FIR is registered, within a year, this is being given. That is, a petition should be filed within a year. And if it is within 6 months, the delay needn't be explained. But if it is after 6 months, a delay for a delay continuation petition is to be put, because this is given as the first interim relief as soon as the trauma is caused to the particular survivor. It's that's a financial assistance given for them, equipping them for a mainstreaming to the society. The second one is the beneficiaries are survivors of all sexual offenses, that is women and children of all kinds of sexual offenses, survivors of acid attack and other burn attacks, then survivors of domestic violence, and survivors of heinous gender-biased violence. These are the category of people who are being addressed in this program. That is, the need of the survivor which is met is the multiple injuries that have been caused to them due to this particular incident. That might be multiple injuries due to the particular violence, to address their mental and emotional trauma. Some of the people would have gone through some irreversible damages, such as they might have become HIV positive or some other kinds of STD or some kind of AIDS kind of disease they might have caught hold of. Then to address the acid attack and burn victims, burn survivors, that is, they have to come out of the injury, out of the trauma, and they have to mainstream, and to address the financial strains of the family. The service delivery system, that is being addressed. Sir, is this the same PowerPoint that have been sent to you that I'm presenting?
Pardon, ma'am?
Is this the same PowerPoint that I've sent to you, that I'm presenting the same PowerPoint?
Yes, ma'am. Service delivery, na?
Yeah, I sent 3 PowerPoints yesterday. Is this the same?
Yes, ma'am.
Okay. The service delivery systems, that is, we have, if there is an immediate delivery system to the child, is being done through the district child protection officer, and for the women it is being done through the women protection officer. As soon as the petition is given by the survivors or the person who comes in contact with the survivor, that is, the police can do it, the child welfare committee can do it in case of a child, and in case of a woman, the service providing centers can do that, or the DLSA can do that. They can just give an application to the women protection officer, and the women protection officer will conduct an inquiry, and further it will be submitted to the Nirbhaya cell, which is running under the Women and Child Development Department, who will do the scrutiny, and we will be releasing the funds within 10 days, within 10 days of receiving the application, and it will be allotted to the district women and child. We have a district women and child officer, development officer in all districts. It will be dispersed to them, and the beneficiaries will be getting it as soon as it is dispersed off to the District Women and Child Development Officer. So it's a very easy process, and they are getting it very soon. Within 15 days of their petition, they'll be getting this amount. And in case of any emergency, it will be released within 10 days. The process will be completed within 10 days. And these are the categories that we are addressing. That is, in case of a sexual assault for a minor, it is from 10,000 rupees to 1 lakh rupees. And in case a minor gets pregnant due to the sexual offenses, she is met with another 2 lakh rupees, that is, which comes around another 1 lakh rupees, which will come to a total amount of 2 lakhs of rupees. And in case of gang rape or any unnatural offenses, that is, it would be 50,000 would be the minimum amount, and which will go around, maximum will go around 1 lakh rupees. And in case of loss of life due to the gender biased offense, it will be 50,000 to 1 lakh rupees. And in case of a domestic violence survivor, the minimum amount that we are giving is 25,000, and the maximum amount is 50,000 rupees. Where any child who has been trafficked or a woman who has been trafficked, in addition to the other amounts, they'll be given 25,000 to 50,000 rupees. In case of an acid attack survivor, 1 lakh to 2 lakhs is the amount that we are dispersing to the person according to the percentage of the injury that has been caused. In case of pregnancy due to any rape or any other sexual based violence to the child, a maximum of 2 lakhs rupees is given to the person. In case of the person gets, due to the gender biased offense, any part of a body or a limb is amputated or any injury is caused, 50,000 to 1 lakh rupees is being given to the particular person. So these are the categories where we are addressing. And furthermore, the coverage of the project, that is in the acid attack, what was the amount that was being dispersed in the year 2019-20 in regard to what has been given in the sexual abuse. The major portion of the amount is released in the sexual abuse, that is child sexual abuse. And in gang rape and unnatural offenses, what has been disbursed of is shown in the chart. And for loss of life and in domestic violence, the major part of the amount was given to POXO survivors, and the next is for the domestic violence survivors. In case of a domestic violence survivor, the WPO, that is a Women Protection Officer at the district, will aid the lady to open up some livelihood for that person with the amount that she has received, and she will be either with the help of the panchayat, that is with the aid of the panchayats, a small unit. They will help her to start a small unit with subsidized loans, and for the initial capital, she can invest this particular money that she has received, and she can find a livelihood of her own. This is the aim of the project, to help the person. And in case of a POXO survivor, we are giving her an immediate medical assistance at the same time to address the financial stringency and to make her overcome the trauma, as well as that she can continue her education with the amount, that is to minimize institutionalization of such children. We have been giving it to the POXO survivors. And here the immediate financial aid that is given, this is an immediate financial aid. It is to overcome the trauma of the first phase of the assault that she has suffered. And the next one is, one of the major things is that child POXO survivors, in the POXO survivors, we are not addressing this to the child marriage survivors in depth, because we are just keeping in mind, and we are scrutinizing that to the main extent, because it might not help us to curb child marriage. If we are releasing much amount to the survivors of child marriage, that would give, that is in a particular society where the child marriage is existing, this would give an additional energy for them to go on for the same practice for the child marriage. So we are scrutinizing that very much in depth, and only releasing the amount in necessary cases in case of child marriage. And further, I had already mentioned this point, how to equip domestic violence survivor. And then the uniqueness of this project is that we are minimizing persons to the institution, because as our studies have revealed that institutionalization is the last resort as per the Juvenile Justice Act. And furthermore, if a woman or of a lady or a child is institutionalized, it will be a very hindrance to her proper growth. So we are maximizing the reduction of institutionalization, and moreover, we are giving this as an exceptional cases. We are giving in exceptional cases even after this 1 year. That is, the project is that FAR should be submitted, and within 1 year they should apply. We are in some exceptional cases, we are giving it to persons even after 1 year, because certain persons will not be able to overcome the trauma even after 1 year. And victim compensation, that is, the state, the judiciary is giving a victim compensation scheme that is not a bar to persons who have already received this Ashwasan Nidhi, and this Ashwasan Nidhi amount will not be reduced or deducted from the victim compensation amount that they are receiving. So this is an additional amount that the state is giving to the survivors. This is the excellence of the project that I am portraying. That is in 2019-20, that was the initial stage of the project. The graph replicates that. In 2020-21, we could meet only this. And in 21-22, the project, the excellence of the project went very high. And in even this year, it is going, because last year we had to reallocate 1.5 crore rupees for addressing the beneficiaries. So one of the major challenges that we are facing is the increasing number of beneficiaries, and we have to find out other sources for exceeding the limit, because it is exceeding the limit that we are. The plan fund is 2 crores and it is exceeding that limit. So we have to find out amount for that. Even though we are reallocating from other funds that we have received, in this year, I think it will go around 4 crores. So one of the major things that we are doing now is we are doing a prevention program. That is, IEC activities are taken out, and campaigns, media campaigns to reduce the sex crimes. At the same time, the reporting of these crimes have increased a lot. The IEC activities and campaigns are being done by the Nirbhaya cell to that extent that all are coming forward to report the incidents of sexual or gender-biased violences, and finding out more fund for the disbursement of the amount. These are the solutions that we are finding out, and the future plans is to spread widespread of the IEC programs among school and colleges, and continuation of the Ashwasan Nidhi project. And for the 22-23 plan proposal, 23-24 plan proposal, we are proposing it to 5 lakhs of rupees. So thank you, sir. This was the presentation with regard to Ashwasan Nidhi.
Ma'am, thank you very much to the point presentation. But I think your 15 days and 10 days reimbursement time itself is too much, because the victim is under trauma during first few weeks. So I don't think that he or she can file an application with the government in the initial trauma phase. So can we reduce this? Second issue is that many crimes go unreported. So can we empower panchayats and other institutions to inform you or government that such an incident has taken place?
So with regard to Kerala scenario, reporting is very high. Because when we take the that is the crime records itself, we find that non-reporting is very less with regard to Kerala scenario. And the LSGDs have been sensitized because we have very good CPCs here in Kerala. At the same time, we have another project called the Jagrata Samadhis, that is in the LSGD, which is working in the village level as well as in the ward level. So the non-reporting is very less here in Kerala. And moreover, here we have to do a very good study with regard to the situation that the child is undergoing. Only after that, the recommendation will be given. In some cases where there is an emergency, I would like to give an example to that. In Kollam district, that is one of the districts in Kerala, we had an incident of a person from Odisha, a girl from Odisha who was brought to Kerala, and she was there was a crime against her from here. That was actually a child marriage, but it was a crime that was registered against her, against the person who had bought her in a POCSO offense. In that particular case, the incident came to the authorities only when the child came to the hospital, because it was a child marriage. They were from other states. and they didn't know that it was an offense. And when as an offense, when it came to the hospital only, it was registered as a crime. As and when it was informed to the cell, we took the initiative to disperse the amount, and 2 lakhs of rupees was dispersed within a week. That is, the only delay was for opening of a bank account. This can be done only through a bank account.
Sure,
So a
sure.
bank account need to be opened. For all this, in the initial stage, time will be consumed, sir. So
Okay,
the
okay.
minimum
Thank you.
time only will be consumed. In minimum time will only be consumed. And this is the maximum time that we are giving as 15 days.
So I think all hospitals and nursing homes, they are also informed about this provision.
Yes, yes. All police stations, hospitals, and all the authorities have been given information with regard to this scheme called Ashwasan Nidhi.
Okay, okay. I don't think any other state, do you know that any other state government has also started a similar initiative?
No, sir.
Okay, okay. Thank you very much. Thank you. Got it.
Thank you, sir.
Really a very innovative scheme. Since now you have mentioned as well that no other state has taken this type of initiative, whereas it should have been taken by most of the states. I would like to know, like if somebody got sex victim and now the female is having AIDS or HIV, as you mentioned. So the treatment in the longer run is also very costly.
Yeah. So we have an AIDS program here in Kerala. This is for the initial trauma, to address the initial trauma, sir. And we have for the AIDS population, we have a scheme under the Kerala Social Security Mission. They will be mapped to that Social Security Mission, sir.
No, since you have started the thing that now the victim has been raped and now she is having HIV. So now the victim needs to again go to the other authorities, or automatically the victim will be covered under. So now she need not go to the government office again, and she will be getting all necessary help from the government for treatment as long as the treatment goes on.
Yes, sir. Yes, sir. That will be done by the department itself. If it's a lady, by the women protection officer, and if it's a child, it will be done by the district child protection officer.
So both the schemes are linked, or they are not linked?
It is not linked, sir. All the hand-holding support will be given through the officers. The hand-holding support. In the particular Ashwasan Nidhi scheme also, the petitioner needn't come to the state office or to the district office. It is all done by the officer reaching out to the patient or to the person, that is to the survivor.
Okay, what is the strength of your organization, those who are reaching to the needy people?
Sir, the beneficiaries, sir?
No, I'm not saying. Like you told that the officer will go to the beneficiary.
Yes, sir.
So what is that system? How does it work? How many employees are there, or they are being done through some system? What is that system?
So in the district, we have a district child protection officer, and under them we have reach out, that is persons that are social counselors. At the same time, we have a program protection officer, non-institutional care, protection officer, institutional care, and furthermore, we have counselors, social workers, outreach workers. They are there in the district child protection office, and they'll be reaching out to the panchayats where the CPCs are working. So to reach out to the beneficiary is very easy. And we have police officers in all police stations, child welfare police officer and women welfare police officers in all the police stations in Kerala state. So it's very easy to reach out to them and to give them all the aids that are necessary.
So the beneficiary should not try to reach to the government. The government is trying to reach to them.
Yeah.
Okay. Very good. Excellent work you have done.
Thank you, sir. project by the Women and Child Development Department that is called Dhira. Dhira in Malayalam means a powerful and very self-confident thing, that is who can come forward. This is one of the first state level project for the young girls. That young girls means from 10 to 15 years of age. We are teaching them martial arts so as to equip them to be very courageous, to say no to any unwanted hands that are moving against them, or to cope up with any situation and to overcome all the trauma. That is one of the innovative projects that we have put forward in the last financial year, and it's called Dhira. It's a project for the adolescent girls, and we train them in martial arts, because in Kerala we have Kalari sort of martial arts, and we have also introduced karate to that, and also taekwondo. All these are the three martial arts that have been taught to the children here. And it is done by professional trainers, which is continuing for 10 months. That is, we have avoided 2 months because it is the month where the children will have to prepare for the examination and other things. And here in Kerala, we have rainy season, which will be very difficult for the children to come to a particular area. So we have taken up the program for first 10 months, and this was one of the pilot projects. So it's a pilot project, and so we have minimized it to 10 months. We'll be carrying over this project for the next year also, because it has come out to be a very good response from the society. And the Kerala government has sanctioned an amount of 68.25 lakhs for the implementation of the program this year, because as a pilot project, we have just targeted a very minimum number of children. Here, this amount, that is that we are giving uniform for each child, refreshment daily when they come for the training, that is per day it is 25 rupees, and we have strictly given instructions that this rupees 25 shall be used for any energy boosting up products only, just like egg or milk. Not any fast food shall be provided to the child when she is coming for the training program, and the trainer is given a remuneration of 1,000 rupees per training. This is to equip the child to be very courageous and to say a big no to all the gender-biased violence that is coming against her, to have a self-defense. If any unwanted situation is coming, how to be equipped to act as a self-defense, then how to develop confidence within her, how to improve her mental health, her physical health, her eating habits, and to get regular exercises, to get sufficient sleep, which is a very good thing that every person should get, that is a sufficient sleep. Then how to create good hygiene in a particular person, and how to be very close to the recommended body weight a person should have, and how to say no to drugs and other substance abuses, and how to have a self-care about the person. And it is targeted to the vulnerable areas. And here the child between the age of 10 to 15 years are selected or inducted to the program, and preference is given to children from the vulnerable families. And the selection of the child is being done in each district by the District Women and Child Development Officer, the District Child Protection Officer, and the CDPOs, and in the LSGD representatives. This is one of the major areas where we should identify the vulnerable families. So the LSGD representatives, the local self-government representatives, are being included to the selection process, and the vulnerable families are identified as child survivors and parents addicted to, that is the children who belong to parents who are addicted to alcohol or other substances, who have either lost both the parents, one or both the parents, and from the SEST remote areas and other vulnerable circumstances. The selection process of the trainers also, we are giving much importance to this, because the trainer should be very good, which shall then only the children will be equipped with all the self-confidence and how to say no to all these things. And they should be very good in the character as well as in the professionalism. They should have professionalism too. So we invite expression of interest from the professional trainers, and the selection process is done by a committee consisting of the district officers And the district officers will do a background study about the trainers, including a police verification is done and an agreement is executed with the trainers to give training to the children. And here the project coverage is to 3 LSG in each district. As earlier said, this is a pilot project. So we now we have just implemented this in each district only in 3 panchayats or 2 panchayats and in 1 municipality. That is the way we have taken this. That is in 3 panchayats, 30 beneficiaries are identified. And so in each district, there would be 90 beneficiaries. So 90 beneficiaries, and we have 14 districts in Kerala. So the total number of beneficiaries is 1,260. Next year, we will be increasing this beneficiaries. So this is the monitoring and supervision of this particular program is done by the Women and Child Development Department, which is headed by the director. And the other monitoring is done by the Nirbhaya cell, which is created under the Nirbhaya policy of the state, or the cell which has come into force as per the Nirbhaya policy of the state. And in the district level, it will be monitored by the district Women and Child Development Officer, and the district level implementation officer will be the district child protection officer. And when it goes to the block level, it will be done by the CDPO, and in the ICDS, it will be done by the ICDS supervisor in the panchayat level for the monitoring. And one of the uniqueness of this program is, even though it has been just 4 to 5 months, we have got very good response in this program. And many of the children itself have come back to us saying that this program should be taken for a long time, and because it has improved their self-confidence and self-awareness, how to be self-hygiene, how to be self-protected, how to enhance their physical and mental. They have enhanced much in their physical and mental health. They have increased their awareness. That is one of the major points that we have got. They have increased their awareness about the gender-biased violence and what is gender. That is, there are not only 2 genders, there are many more genders that they have to understand. They have given awareness about that. And there is a wide acceptance among the general public with regard to this program. And one of the challenges faced by this program in the first stage is that we have found a very much difficulty in finding out the beneficiaries, because in the vulnerable areas, there'll be much more children, but we have a restricted number. So we had to restrict this to the first year. Next year, we will be increasing that, and the selection process of the LSG, because all the LSGs want this program in their particular area, but we could not give it to all of them. Now only the program is being run in 42 LSGs. Then the solution future plans for the program is increase more beneficiaries to the program so as to enable girls from all strata of the society. That is, all of the children all the girl child should come to this, because we always feel that the vulnerability is there only in some particular areas. But we have come to know that the vulnerability is there in the urban areas as well as in rural areas, and empower the children in our state so as to eliminate violence against them, and to expand it to all LSGs, and to impart continuous training on martial arts to all the young girls in the society, so as to equip or to achieve the goal, that is a free violence state. Thank you, sir.
Thank you, ma'am. Excellent work. I also support the idea of the young girls who have received training that this program should be continued over a longer period.
Sure, sir.
I think it can be extended even to university level or higher educational institutions also.
Yes, and as of now, we have taken the criteria from 10 to 15, because from that age onwards, they should be trained, because many of the martial arts needs flexibility in their body. So it should be started in a very young age. That is why now we have targeted it from 10 to 15. We'll be extending the program to the other age groups also, sir.
Thank you. Excellent work, ma'am.
Thank you.
Work is really good, but I could not get what is innovative in your scheme.
Yes, sir. Okay.
What is innovation? Because now you have applied for SKOCH award. So what is special in your presentation, or which I could not get?
Sir, because in the vulnerable areas, Usually in schools and other places, the children will be taught with regard to the martial arts. But in the vulnerable areas, especially in the tribal areas, as well as in the SE communities, they would not be able to give such a big fees to the trainer and to get themselves educated on this. And when we had a study with regard to the sexual offenses among the children, we could identify that the major percentage comes from this vulnerable group. That is either the parents, single parent, or with regard to the parents who have been addicted to any kind of substance or alcohol, and from the SC/ST areas. Here, what we could identify is that these children, because of their vulnerability, they didn't have a self-confidence, or they were not able to resist the violence which were coming against them, or the unwanted hands which were coming against them. So as to equip them, this is what we have taken up, because our state, where we have a huge number of reporting of offenses, and when we took the percentage, the vulnerability area was this particular area. So we thought that this should be identified. We should develop self-confidence in them, and the self-confidence that we can develop is by the state hand-holding with them and giving them an opportunity to come forward with this kind of training. So it has helped them a lot in this. Many of the children from those areas who were who have become survivors had told us that if this training we had given earlier in a smaller age, because a child of 15 years of age, she said, if I had got this in my 10 years of age, when I was abused at the age of 12, I would be able to resist, because knowing that this was an abuse and this was how I should resist against it. That is why we have applied for this innovative idea, sir.
Okay, good. Thank you.
So this project was conceptualized by our mission director, Dr. M.S. Lakshmi Priya, NHM Assam, and we, the team members, we work on the framework and the guideline of this project. Okay, so this project Pokhila, the Pokhila word stands for Pool of Kind-Hearted, Inspired, Last Mile Activists. So this project was conceptualized by our mission director, Dr. M.S. Lakshmi Priya, and the framework and guideline is devised by us, the NHM team. The forward is, so it has been seen that health department, although we have been able to reach the remotest of areas in the state of Assam, still there are places which are still unreached and yet to be covered by health department. And also where the health department has reached, there exist people who resist the healthcare system, who do not want to seek healthcare services from the NHM or the healthcare system of the government of Assam. So for example, there are many identified cases of severely acute malnutrition children, then moderately acute malnutrition children. Our healthcare service providers, they go and identify those people and advise the parents to take these children to NRC. NRC stands for Nutritional Rehabilitation Center. So these exist. Our first line workers like ASHA, ANM, and multipurpose workers, so they visit them, but there are still families who resist these kind of advices from healthcare service providers. So what happened? The children are left out, and as a result, in our country or our state, this incidence of SAM and MAM children are growing, and as a result, the infant mortality as well as the under 5 children mortality is very high. So it is from that the concept generated that if we provide proper counseling to this family, because many cases these ASHAs, ANMs, although they are doing very good work in the field, but it has been seen then when they advise, the advice is haphazard and it is not a structured way, and they could not convince such people or such families to mobilize their children. So it is felt that if proper counseling with scientific approach in a structured way, if we counsel these people, if we provide the psychoeducation to these peoples, then we could be able to convince them and mobilize these people to take appropriate healthcare. So keeping this in mind, this concept of Pokhila team was developed. So introduction, the word Pokhila is actually an Assamese word which stands for butterfly. So the concept is like this, that the butterfly flies from flower to flower, and what it does, it carries pollen grains, and it creates the beginning of a new life and new thing. So similarly, this project
Tashi, I think your slides are no moving. I can see only your first slide.
okay, which is an Assamese word for butterfly. So as the butterfly flies from one flower to another and carries the message of happiness and joy in its colorful wings, and shows the beginning of new life and change, in the same way, the state of Assam has decided to bring all counselors, the counselors and other frontline workers who are engaged under different health programs under the tag name Pokhila. And we want to use the counseling expertise of all these counselors so as to ensure that the people take the messages from these counselors and the expected behavioral changes are seen towards positive healthcare. So it is hoped that this initiative will ultimately improve health-seeking behavior, and it will result in health systems more responsiveness towards community needs. But I want to stress that it is not a substitute for ongoing activities. The people who are working in this project Pokhila, they are existing employee of NHM, but they will not be diverted from their original work. They will only contribute in the resistant cases or such cases which are not being able to being taken up by the frontline workers. So it is not a substitute. The project Pokhila is not a substitute for ongoing activities. So it is also not an emergency service provider. Suppose at the middle of the night, someone becomes very ill. So project Pokhila will not be mobilized, but in that place, the normal mechanism which is available in this healthcare system, that will be activated. So now Pokhila project, here we have divided the team block wise. There will be 3 teams. The first team who will approach these resistant families, that will be the block team. So block wise we have divided the team, and each block will be headed by one counselor having a background in psychology or sociology or social work or mass communication. So anyone having this background, they will be heading one of the block, and under them there will come other employees such as block coordinator, block community mobilizer, then this block extension educator, multi-purpose worker, health educator, and ASHA supervisors. So they will come under block team, and they will be headed by one counselor having a background in psychology, sociology, or social work. At the district level, there will be a team which will be consisting of these counselors, then district community mobilizer, then district media expert, then joint director, and the respective sectoral MO. In the district team, when a particular case is not convinced by the block team, then the district team will be activated. At that time, the sectoral MO of that particular area will be involved in the district team, as well as the SDM and HO. The subdivisional medical and health officer, he will be also the part of the district team who will visit the resistant cases. And there will be a supervising team headed by the joint director of the district. So this is a draft logo of Project Pokhila. So what is the objective of Pokhila? So Pokhila team is not a substitute for the ongoing activities. The individual members will continue to do their respective work as per the terms of reference in the appointment letter. However, as a team Pokhila, they will provide specialized counseling services for the difficult and resistant cases for mobilization. So we will target mainly this teenage pregnancy, and we also try to target this teenage marriage. Again, out of school children, where it has been seen that many in these rural areas or peripheral areas, many children, they become out of school as early as 12 years of age or before that. And when they become out of school, so the parents force them to do either take up some jobs, or they force their girls to either get married. So this is the problem. So as a result, what happens, teenage marriages are happening, and teenage marriage is contributing a major portion of infant mortality as well as maternal mortality is coming from these teenage pregnancies. So we are targeting this teenage pregnancy and out of school children, as well as Team Pokhila will follow up all the high risk pregnant women and will coordinate for their institutional delivery at the appropriate facility. They will also visit those families who are resistant to seek healthcare for their severely acute malnourished child or moderately acute malnourished child. So Pokhila team will counsel and mobilize them for treatment under NRC and also provide psychoeducation. So Pokhila team will also do the 3rd trimester pre-delivery counseling as well as the postpartum counseling of the primary cases. So most importantly, the Team Pokhila members, they will visit the houses of resistant group, any resistant group which are identified by these ASHAs or MPWs, and will motivate them to seek healthcare. So the training part, we are, although the counselors are working from long, but we have already trained them on online mode, and orientation has been given, but we are planning for physical training. The project Pokhila is new for us. It has been only 4 to 5 months. So in the next month, we'll bring them together and train at the state level, and the training will involve one-to-one training, then workshop mode, then there will be role play, then we'll do training on actual patients by visiting the field. So this is the plan of action in the future course, and the training will be done from with the help of one institute. For example, we have Lokopriya Gopinath Bordolai Institute of Mental Health, which is placed at Tezpur. So we'll seek the help of these mental health institutions for the training of our counselors and psychologists. So how we'll intervene, how we plan to intervene. So this is the main part. Suppose ASHA or the first line worker, they identify that a person or the family has been approached multiple times by the ongoing activities or the ongoing programs. They have been reached by them multiple times, and still they are not able to mobilize. They are not able to convince the parents or the families or the husbands to bring their wife or child to the healthcare system and seek treatment. For example, many high-risk pregnant women are still sitting at home. They are not getting antenatal checkup. They are not getting their injections. They are not getting iron folic acids. So such people, when the ASHA identify, so we have seen that with each ASHAs, there are 1 or 2 such families exist. So the ASHA then will pass this information to the block coordinator, and the block coordinator will pass this information to the SDMHO, and the SDMHO of that block will sign that this is a resistant case. When this SDMHO and the nodal officer, when he verifies that the case is resistant, then the block team Pokhila is activated. And what they do, they will move as a team. They will maintain a decorum. They will move as a team and go and visit that family, and it will be headed by this counselor. And the counselor, what will they do? They will first listen. What are the problems? What are the complaints of the families? Why they are not getting mobilized? And identify the cause of resistance. So for example, many times it has been seen that in maternal health sector, there are some myths and misconceptions, like consuming iron folic acid and any other supplements make the fetus grow big and results into difficult labor. Such type of misconceptions are still prevalent. Also, there are concepts that supplement provided free of cost from the government are inferior of quality, and there is also this misconception that it is considered inauspicious to disclose about pregnancy before the completion of first trimester. So as a result, we are not able to register these patients. So what will this Pokhila team do? They will go, they will listen, they will identify the cause, and then they will devise a plan how to counter that misconception or the myths or the resistance. And as Pokhila team, the members will be in a higher ground, so they are in a position to advise the family. First, they will advise the family that regarding the seeking healthcare and why it is appropriate to seek healthcare and take treatment for their family members or the child. And after advice, they will give psychoeducation. They will talk about the programs. They will talk about the disease they are facing. They will talk how to counter it and the scientific basis of these diseases. And they will psychoeducate the patient or the family.
So sorry to
After
interrupt you.
psychoeducation,
You have another 2 minutes.
okay, sir. So after psychoeducation, they will counsel the family. So this way, we are planning to mobilize the families to seek healthcare system. So outputs. So we are expecting that after a period of 6 months or 1 year, we will be able to see results by reduction in teenage pregnancy, in reduction in maternal mortality. There may be reduction in infant mortality and child mortality, and there will be increase in healthcare coverage. So at present, we are compiling or collecting all the data, all the activities which are being done by team Pokhila, and later on, at present, we have not done any statistical evaluation, but in the coming months, we will do this, we'll compile these data and we'll do statistical evaluations also. So Pokhila will evolve gradually. At present, it is implemented in 10 districts of Assam, and gradually we'll, after seeing the result, we'll implement it in all the 32 or 33 districts of Assam. So in brief, the project Pokhila is a specialized counseling service. It is a systematic approach to target the resistant families by structured counseling. So that's all, sir. Thank you.
Thank you, Dr. Saab. Excellent project. And in fact, what is the incentive for ASHA workers to report such Pokhila cases?
Sir, at present, incentive has not been there because already we have data that each ASHA has such cases, 1 or 2 such cases. They will just have to mention the names to the block coordinator, and the block coordinator will do the rest of the work. But in the future, we are contemplating the association of some developmental partner, and also from the NHM fund, we are contemplating that frontline workers will get some kind of incentive if they report such cases.
I have a suggestion, Doctor. I think if you deal this whole strategy, since now it is only 5 or 6 months old project, you deal this issue on a digital platform so that there is a real-time information sharing, and the time taken will be less to provide help to the these malnourished persons.
Yes, sir. Yes, sir.
I think this is very good. Otherwise, is it a good project to reduce IMR and MMR cases? Even if you implement in successfully, even in 5-6 districts, it will be a great help. Excellent work.
In fact, we are in talk with some developmental partners for this digitization of this process, sir, actually.
Yes, yes. Then only it will bring transparency, efficiency, and it will definitely, it will be a very good, what you are talking about, that we will keep a data. The data will automatically be generated, stored, analyzed. It will have a good analytics, and you can say on a tracker mode.
Yes, sir. Yes, sir. Definitely. And we are in fact in talk with some developmental partners for digitization of this. And in the coming months, we are hopeful that this will happen, sir.
Even this ASHA workers, they will also be motivated. Yes, they have reported so many cases.
Yes, sir.
They will also feel enthused to do their good work.
Yes.
Thank you, Dr. Saab.
Thank you, sir.
Dr. Saab, really the work is worth appreciating. And the only thing, as Mr. Sharma has also mentioned, that capturing data on real-time basis, and the people should be and the ground workers who are front line workers, whosoever is going to the remote areas. So their data should be captured. If online and transparent system is being developed, then you can get more benefit out of this scheme.
Yes, sir, definitely, sir. And within these 4 months, we have changed, visible changes are there. And we are getting reports of mobilizing multiple cases. We have seen high risk pregnant women cases, women who are severely anemic and having twin baby, they are saved by mobilizing those persons, because the husband was not active and husband was not taking her to the hospital, but the team Pokhila, when they visited, they convinced and they themselves mobilized by psychoeducating the person. So such visible changes and results we are getting. And also teenage pregnancy, teenage marriages, we are able to, till now we are able to prevent about 10 to 15 teenage marriages as of now in the last 3 to 4 months.
The real success will happen to this program only when you will be able to reach to the remotest places in your state.
Yes, yes.
Right. Thank you.
Okay, thank you, sir.
Good afternoon. I'm Dr. Rajnil Bhattacharjee, ophthalmologist, consultant for NPCB NVI, National Health Mission, Assam. I'm representing Dr. MS Lakshmi Priya, IS, Mission Director, NHM Assam. I am going to present this project initiative by our Mission Director, Madam MS Lakshmi Priya, named Saubhagya Sakhi. This is a buddy pair pregnant woman and mentor mother buddy group. This has been initiated by our mission director very recently in around from 1st of the May of this year. So actually this was conceptualized due to the incidence of high MMR and IMR in the state of Assam. This is actually one of the additional components to reduce the MMR and high IMR of our state of Assam. So in this concept, what has been done was that 2 pregnant women from the same village with a similar gestational period are to be identified as buddy, and they will be mapped together as buddy, so that both of the mothers, pregnant women with similar gestational period, can be followed up together. And also they can share among themselves their feelings and any other support they want to give each other in any form whenever they need it. They will be like a as a both as a pair they are considered, and they can among themselves they can share whatever they want to share, and their problems, their solutions, and whatever they are using for themselves. So since they are considered as a pair, so both the pregnant women will be called for the same VHSND sessions, which are occurring in their village. That is Village Health and Sanitation and Nutrition Day, where they will be talking about health and nutrition and childcare and sanitation and all those nutrition, about those things. So since they will be together, they can share among, they can discuss among themselves whatever they have queries, and implement on that together. Though buddy pregnant women will also help each other to motivate for proper pregnancy care and to attend the VHSND sessions. What we have found is that Assam, lots of pregnant women do not attend to the healthcare facilities, or do not go for those sessions, and they have a resistance to access the healthcare facilities and home deliveries. So these formation of groups will, if one pregnant mother is going, so another pregnant they will tell that other mother that I am going to that hospital, why don't you come to me also, you are also having the similar problems, so we can get the solutions together. And like that way, since they will be having similar gestational age, so they will there will be similarity in their problems and their nausea and vomiting, this similar problem. So this is to motivate so that they can access the healthcare together. Now furthermore, one new mother from the same village of those two buddy pair mother who has already delivered, that is newly delivered mother, are to be identified and need to be mapped as mentor mother so that she can provide guidance based on her experiences during delivery and pregnancy. That is one mentor mother who has recently delivered. She has gone through this pregnancy and delivered the baby. She can share her own experiences with the two buddy mother, so that if the queries of the buddy mother or anything will also get resolved. The mentor mother can herself say from her own experiences that I have suffered from these things, so these things are very common, or I have went to the hospitals and got this result and the healthy baby, or they can share themselves together, the three people together. So the buddy pair pregnant woman and mentor mother together will form as a team. Now, the mentor mother will provide support during antenatal period, postnatal period, and immunization of the child of the two buddy pregnant women. So, but however, both the buddy mother will gain psychological support and other good practices among themselves during pregnancy. From that mentor mother, the buddy mothers will gain information regarding the immunization or the medications they might, the regular medications they have to take or whatever they have been prescribed. They will get the support, and also the support that some pain will be there and it will get reduced after some days, and those sort of similar questions, whatever. And although buddy mother and mentor mother will be linked with self-help groups so that they can improve their living conditions, and so, because a lot of husbands of those poor mothers are not working, so the empowering the mothers also will help in the implementation. So this is the group, that is the mentor mother and two pregnant women of similar gestational period will form as a team. The ashas or ANM will regulate their meetings, and they will also their queries and everything she will also sort out. She will ashas and ANMs will map them together so that they can that there is better acceptance of the health facilities and mobilization of the patients. So this concept comes at no extra cost, so it is a very cost effective thing. It is just an additional to the ongoing activities which are already there, and all the activities to reduce IMR and MMR are being done, and it is just in addition, so that people are more acceptance of the healthcare facilities and to reduce the home births and everything. To speak about the uniqueness, this is a newer concept introduced in this to reduce MMR and IMR. It has been done in other HIVs and all in other African countries, but in this Assam and all, this is a newer implementation to reduce, which is an additional. The most of the challenges what we have found in this short period is that the community acceptance takes time. People are not like we won't be going to meet the other mother, why will I go, or not coming. That has been a challenge, but it's a possible thing, and we are doing in all over the Assam, and it has given good thing. The coverage is to include the whole of the Assam. It has been implemented in all over the Assam only, but there has to be more implementation or coverage of actually involved. The future plan of this concept is to involve all the pregnant women of the state, and the mentor mothers and everything, all should be take part in that buddy mother concept. This is a picture showing where the ANM and Ashas are there with the buddy pregnant woman and mentor mother together, who are sharing their feelings and everything. Now, Baby and Mother Center is a birth waiting home which is in close proximity to district hospital or high caseload facility, where expected body pair pregnant mothers, mainly high-risk pregnancy and pregnant women from difficult areas, will be brought at mother and baby center, where they will stay prior to delivery. The mentor mother will give support to them during this period whenever needed. This has been done to increase the institutional delivery of the mothers, and it improves the monitoring and care of mother and newborn baby, and it provides a clean and hygienic environment, and free diet facility is also provided. So the body pair pregnant mothers will who are having high risk pregnancy can along with a normal pregnancy can come to this center, and the mentor mother will, if possible, will come to there and share her feelings and give support. So this is the maternal death source from our SSD portal. This compares the actually last year's April to September maternal deaths and this year's April to September deaths. This is the cumulative effects of all the facilities, because we haven't evaluated our short concept in a recent, but we'll be further evaluating the effect of this concept in our recent days. But it has shown that at least from April to September of last year, there has been reduction of around 25% of maternal death. So that is, last year there was around 384 deaths, and this year around 289 maternal deaths. This is the district-wise maternal death, which shows there are reduction in maternal deaths from last year April to August to this year April to August around in most of the district, with and few districts having little bit increased incidences of maternal death. But mostly in cumulative, if you see the in total, this has been reduced. And this is the trend of child death from our same SSD portal from last year, comparing April to September to this year April to September. In last year there was around 3,842 deaths, and this year there has been around 3,484 deaths. That is around 9% reduction. So this is also due to the cumulative effects, but we'll be further evaluating all the this impact of this concept in recent months. And this is also showing the district-wise trend, where there have been most of the districts have been in reduction, with few districts only which have increased incidences. So to finalize, the project Shobhagya Sakhi, it is a good governance towards the sustainable development goals. So thank you.
Thank you, Dr. Saab. The idea of creating this collective wisdom and providing emotional support, promoting institutional deliveries through this system is definitely very good. But ASHA workers should be told that it is not a substitute for expert advice.
Yes, sir.
They should be clearly told.
Yes, sir.
Otherwise, it can be misused also.
Yes, sir. So yes, sir. That's why only, sir, to prevent misuse of information or communicate misinformation, ASHAs and ANMs will be there to the meetings, where if they are speaking to a negative way, or if they are the meeting is going in a negative way, maybe like they might be start talking about their household problems and everything. So to regulate the meeting also, ASHAs and ANMs will be there to regulate the meeting.
Definitely. And I think your IMR and MMR caseloads, in fact, is very unsatisfactory. But anyhow, let us hope that it will be reversed soon.
Yes, sir.
With this initiative. Thank you, Dr. Saab.
Thank you, sir.
Yeah, it seems to be an excellent scheme involving self-help groups and going to very grassroots level and directly making groups of needy people. Thank you. No specific.
Thank you, sir.